Welcome, everyone. My name is Blake, and I will be your moderator this evening. Tonight, we're joined by Dr. Gantos for the Absolute Beginner's Guide to Implant Dentistry. Before we get started, I'd like to take a moment to go over some housekeeping. If you have a question, please type it in the box labeled Q&A as we go through the presentation, and we will answer them at the end. Schein is not offering CE credit for viewing or attending this webinar live or on demand. Thank you all for joining us tonight, and now I'll pass it over to you, Dr. Gantos.
Thank you guys all so much for giving me some of your time. I'm sure everybody is nice and tired, and you've probably worked a full day like I have. And so hopefully I can make this, really high yield, but also be really efficient with all of our time here on a Tuesday evening. So thank you for joining me. So this is the Absolute Beginner's Guide to Implant Dentistry. We're going to talk a lot about basics and then just sort of review how we utilize technology to help us, produce really predictable outcomes. So agenda, I'm going to give you a little bit of my background info. We're going to talk a little bit about diagnostic surgery, restorative implant basics, and then just go through a couple quick, simple, easy cases of how we utilize all of the technology to help us be really predictable in our outcomes. And then we'll take some questions. So a little bit about my story. I am a Michigan State grad. I did my dental training at the University of Illinois, Chicago. And then I did a 1-year advanced education general dentistry residency at the Veterans Hospital. That was where I did a lot of robust implant training. I've also completed a 300-hour implant maxi course. And then with respect to some of the digital workflows, I've done a lot of advanced training through Plan Mecca and through the Mod Institute, which I'll give a shout out to at the end of the presentation as well. I have my mastership in the Academy of General Dentistry and also my mastership in the College of Sedation. So this is my office. I am a general private practitioner in Naperville, Illinois, about 45 minutes outside of the city of Chicago. And, this is on the right side is a picture of my office. And I do a little bit of everything, but a lot of what I focus on are cosmetics, sedation and surgery, and then digital workflows. This is my team. I have to give them a shout. I am very fortunate to work with incredible young professional women who are just phenomenal at what they do and really help, enable us to provide the highest quality care for our patients. So a little bit about my digital journey. I graduated in 2014. I did my AGD in 2015. In 2016, I acquired my practice. In 2019, I did the new build out, which are the photos that you saw. When I did my build out, I put a CBCT in. That was my first big purchase. And then shortly after, we added on scanning and milling. And that was such a wild success for us. We actually added on a second scanner a couple months later. And then we started getting into 3D printing. So my first printer was a Sprint Ray. After that, we started getting into more advanced types of design and 5-axis milling rather than just 3-axis milling. So we, acquired our Plan Mill 50S along with our Plan Mill 30S. We really utilize, a lot of Plan Mecca's digital workflows. So we have all of their equipment. And then in December of 2021, I started a digital dental residency at the Mod Institute. So that is a program located in Charleston where you can learn all different types of digital workflows between scanning, milling, printing, just a little bit of everything. And then in January of 2022, that's when I really revamped a lot of my implant workflows that I'm going to share with you. And then in February and March and September, we just have been accumulating and acquiring more and more 3D printers and different types of digital technology. So I always like to share, why I am, here speaking with you and why I feel so passionately about the material that I'm going to speak about. And it's really because incorporating digital dentistry has been so transformative for my practice, my patients, my team, and what we do. It's really allowed us to be super duper efficient and, accurate in the results. It allows us to make a really comfortable, predictable patient experience. And it's super thorough, right? We know that we have everything documented really well, and that we're being as precise as we can. And then, of course, it's super fun. So it keeps me engaged, my team engaged. It helps our patients, really be co-diagnostic in what we're doing and really show them what we're doing and build that value. I did include it in this presentation, but on our website, we have patient testimonials. And one that I always love to share with people that's so funny is, an elderly gentleman named Bob, who I love, and I've done a lot of work on him. We have a really good relationship. So I brought him into our office to do the patient testimonial. And, they're asking him all these questions, and I'm waiting for Bob to sing my praises and talk about how great my team and I are. And it's the funniest video because all Bob talks about is the technology in our office and how technically competent we are, and how that's how he knew he was in the right place. And, it's really impressive to patients, and they really love and buy into all of the digital workflows. So what are we here to accomplish? We want to learn how to identify suitable candidates, how to, make sure that we are appropriately planning and diagnosing, these cases. We want to prevent, of course, any type of malpositioning or infection or complications and adverse outcomes. And then we want to understand, what does it mean and how do we really treatment plan from the crown down for our dental implants? Whether you are doing the surgery or whether you are working with a surgeon, ultimately, if you're the restorative dentist, you are the person responsible for seeing that case from point A to point Z. So just understanding how we do that really effectively. So excellence is never an accident. It's the result of high intention, sincere effort, intelligent direction, skillful execution, and the vision to see obstacles as opportunities. So we want to be very intentional, there you go, about what we're doing. So this is a case that I'm sure everybody can relate to. I don't refer a lot of dentistry out because I do a lot of dentistry. And so this was a case probably about 6 months ago that was sent to me now. And it was Dr. F had referred me this case. And this is an oral surgeon that I don't work tons with. And I was like, oh, that's great. He's referring me something, what a fantastic opportunity. And then this is what I was referred. And it just really, it's comical, but it just sort of re-cements the fact that being able to have full control from beginning to end, again, whether you're the one placing the implant or not placing the implant, is so important, right? Because there's nothing worse than getting sent something like this and having to restore it, particularly on an anxious patient or, different things like that. So it just sort of reiterates how important it is to be, really the master of our patients' treatment and their treatment plans. So our first objective, again, we want to learn to identify suitable candidates in cases with appropriate diagnostics, planning, strategies, technologies, and products. So some implant basics, right? What is our responsibility as doctors, as general dentists? Our responsibility is to identify and prevent disease. So bone loss is disease, right? It's a metabolic condition accelerated by loss of teeth and an ill-fitting prosthesis. So we need teeth or we need implants to stimulate bone and ensure that we're maintaining the jawbone for our patients. So implant dentistry is really a preventive treatment modality to combat bone loss as a disease, right? Of course, it's functional. We're building back teeth. We're building, function and aesthetics, but it's also preventive. And so it's important to remember that this stuff is really important, right? We don't want to let our patients lose bone that we're never going to be able to get back. So our restorative goals, we want to restore contour, function, comfort, aesthetics, speech, and health, right? So there's such a multifaceted amount of considerations that go into play, which again is why with proper thoughtful planning, we can ensure that we're doing our best to serve our patients. So principles of successful implant planning, we have to know, right? Where do the teeth go in the face? So we need to look at our lip line, the occlusal plane, the general periodontal health, soft tissue dimensions, right? The interarch space, the occlusion and the occlusal demand on whatever tooth or restoration we're going to be putting in there. Patient force factors, what our final prosthesis is going to be, what key implant positions we may need, the amount of available bone density, how many implants, what type of implants, are we immediately loading or delaying that? How are we maintaining things? So many various factors go into play, but understanding how we take all of these factors, evaluate them so we can ensure that we are having really predictable outcomes for our patients. So Dentless site requirements. So for a standard diameter implant, 10 millimeters in length, we want at least 6 millimeters of buccolingual width. Ideally, we really want 7, we'll take 8 and as much as we can get, right? We want ideally for a 10 millimeter length implant, right? We want 12 millimeter depth into bone, 7 millimeters of mesiodistal width for an anterior, and 8 to 12 in the posterior. When we start getting bigger than 12 millimeters, right, we may want to be reconsidering how we're designing things. Do we need 2 smaller implants? So, really understanding what is the mesiodistal width of adjacent teeth, contralateral teeth, and being thoughtful of how we plan those cases out so we can communicate that at the beginning with our patients, right? And not surprise them in the end when they have a different type of restoration that maybe they weren't expecting. We want 5 to 7 millimeters of occlusal clearance. If we have less than 7, right, we want to be considering possibly screw retained restoration. And we want to make sure that we are about 2 to 3 millimeters apical to the adjacent CEJs so we can get the correct emergence profile. And keep in mind, about 70% of the US population is missing 1 tooth. So this is important, relevant information that we should be looking and talking to our patients about. So we've all heard, of course, bone sets the tone, tissue is the issue, but keep in mind that the buccal plate sets the fate. So we want to make sure we have that buccolingual width and dimension and that we're being really mindful of positioning this implant for long-term success. So other considerations, force factors. So understanding how our implant is going to be loaded is a lot of what this is talking about, right? So how much force are we putting on the implant? Where is it positioned in the arch? Because of course, posterior implants are going to get more force on them than anterior. Who's the patient? What is their, mascatory muscle dynamics, right? Is this a square jaw with huge masseters? Because we're going to think about that differently, right? And how we plan our occlusion on it and possibly maybe tying implants together. Of course, we want to minimize cantilever forces. Implants do really well when we load them in the long axis of the body, right? So we want to make sure that we're being really thoughtful. And again, this speaks to really meticulous planning in our surgical phase so that when we get to the end, we have all of the factors in line to make this long term. So our second objective, we're going to talk about preventing different types of complications, how to make this process really predictable. So for me personally, I had a lot of implant training, but I really still liked to more so quarterback with a surgeon for, a lot of years when I first got into practice. Being a new practice owner, I was busy with that kind of stuff. I was doing tons of dentistry, and it just seemed to me something that I preferred to coordinate with a surgeon. And I did everything freehanded. I never did anything guided. So I would cherry pick all the easy stuff and I would coordinate all the harder stuff with people around me. And this was really the case that totally changed all of that for me and really made me appreciate that I wanted to be the person responsible for every aspect of the treatment and the care, and that I really wanted to, make sure I could dictate my patient's outcomes. So this is a patient, the top, these are both photos taken with her iPhone. The top was a photo she took the day she had the accident. I believe she was running and tripped and fell. 9 avulsed completely and 8, of course, shattered, and then some chipping on 7 and 10. She went and saw her dentist. Her dentist kind of splinted everything together just to get her stable. And her cousin was a former dental student of mine, and the dental student referred her to me. So she shows up This is actually right at the end of like COVID lockdown, April of 2020, she shows up. And her teeth look like this. And so, of course, we jump into action. And, she has, you can't really see here, but she has a pretty high smile line. She's pretty gummy. She's beautiful. She's young. She has all these, really robust pink tissues. So I didn't want to place this implant because I didn't want to be responsible for it. We also had to really convince her to place this implant because her sister-in-law, who was a hygienist, kept telling her implants were fake news. And it was like a whole thing. So after a FaceTime with her and her husband, reviewing the treatment plan, assuring her that this was the right thing, we coordinated with our surgeon who did not use CBCT at the time. And I did not plan it. I did not give him a guide. I did not tell him anything, right? I said, place the implant and send her back to me for tissue training on that day. So he places the implant. He sends her back. This is the same day the implant is placed. This is our provisional. I snapped a really quick photo that day. I don't even know where this photo is, but snapped a quick photo of it because I loved my temporary, I loved the tissue support. I loved the contours. I was really proud of it. Thought it was fantastic. So she leaves and she comes back, a week or two later, and the tissue's kind of red and it's a little bit funny looking. It doesn't look right. And she's a little bit tender and sore. So, I take my temporary off, I under contour it more, I polish it, I put it back. It still doesn't resolve. She comes back. So then I think, you know what? Let me take a CBCT. So I take my CBCT and this is what that looks like. So our implant is outside of the facial plate. So I send this to the surgeon and, respectfully try and kind of coordinate and say, because the surgeon keeps telling me, oh, it must be your temp. It must be your temp. Just polish it more, polish it more, polish it more. So we send this to the surgeon and it turned into a little bit of a debacle where, the surgeon felt like the placement was really good and the patient was just having a hard time really adjusting to it. And so this was really that case where I really regretted not being the person to really own it and make sure that I had everything the way that I wanted it. So after this case, I decided that I was going to, do everything that humanly felt possible that I could do and was within the scope of my care and do it guided and really make sure that I can control that. And so this is how that patient ended up. And so with respect to how we go about working up an implant patient in our office. So it's typically a 50-minute visit if it's a new patient coming in specifically for that, or it's about a 30-minute visit if it's someone that is routinely having care that I've seen, and then it's typically an assistant-driven process. So first thing is an evaluation. Of course, we want to make sure we have the right hard tissue, soft tissue, occlusion, force factors, all those things that we talked about before, right? So if this is a new patient, those are things that I'm going to be assessing. If it's someone that's been in our practice, those are things we've probably already assessed before we've appointed them for this visit. And then the patient comes in, we take some photographs, both extraoral and intraoral. We do full arch scans and bites, and then we'll take a CBCT. And we take all that data and we merge it together, which is what we'll talk a lot about doing. And then from there, we can plan everything out. So we can plan our implants, our prostheses, we can fabricate the surgical guide, and all of that is really quick. So there are times where I'll have the assistants do the scans and do the CBCT first. And then while they're taking the photographs, by the time they're done with the photographs, I've already have the case planned. I have everything ready to go, and I can pull that right up on the screen, or my treatment plan coordinator can do that in front of the patient and just sort of review with them what we're looking at and really build that value and show them that, hey, we map out your nerve, we make sure we're keeping you safe, all the different nuances and things to show them how meticulous we are and what we look at to make sure that we're doing a really high quality job for them. And then, of course, after that, treatment plan, coordinator, whoever in your office will review the case, discuss finances, and obtain consents. So my armamentarium, the scanner of choice I use is a Planmeca Emerald S. I really like this scanner because it's lightweight, it's slim, it feels good in my hand. When I was picking scanners, I just kind of held all of them, looked at all of them. And for me, it was a big deal to get team buy-in because this was the first time pretty much anyone on my team had used a scanner. So I really wanted to be intentional about not having it be something that sat in a corner and I would look at every day and feel upset nobody was using. So I wanted something that felt good, was easy to use. We rest this on the teeth, it moves really fast, it's user friendly. So that's our scanner, but any scanner works, right? You just have to be able to get an STL file. And then our CBCT of choice is Planmeca. They're Pro Max Classic. I love this for a lot of reasons. The ultra low dose is really nice, so we can take these scans and we're not radiating our patients. We get buy-in. It's not hard to explain to patients what we're doing and what that radiation dose is. I really love Romexus. So Romexus we'll talk about also, but it is the software that Planmeca uses. So the scans I take with their scanner, the DICOM files, the scans we take with our CBCT, if we're designing crowns and CAD CAM or doing smile designs on photos, all of the data is stored in Romexus. So it's the software that houses everything. It's where we can make the surgical guides. It's just really, really robust, and it makes it really easy. So I'm not having to upload and export and import and do all these different things to try and marry all the technology together. It makes it so that my assistant can scan and take a CBCT, and before the patient walks out the door, I can have it all together. That's really huge and been beneficial for us. It also has a lot of storage, and it's also very easy to send to other offices. So you just kind of click a button and it'll send it right through the cloud. This is Romexus. So Romexus has, again, all these different modules. So it has our imaging module. It has a smile design module where we can show patients what it would look like to fill in that missing tooth. It has model analyzer for analyzing space, right? If we want to, check different dimensions or, do any type of space analysis or look at the occlusal heat map to see how hard are they hitting on certain teeth. The implantology module, which of course we're going to be talking more about, which has the guide design with it. And then PlaidCAD Easy, which we'll also hit on a little bit because that's where you can design the crown and you can take that information and use that to help make your guide and plan your implant. And then there's also PlaidCAD Premium. So PlaidCAD Premium is a more advanced lab grade software. This to me is like the most exciting, mind-blowing software. It's so limitless. It's kind of like, other design software. I always say it's sort of like you have your box of crayons and you're coloring in the lines in your coloring book. PlaidCAD Premium is basically a blank canvas with a bunch of oil paints. You can quite literally create anything that you want to create in this software. So we do a lot of bite splints. Again, you can do indirect restoration, so we can make our implant crown if we want. We can do a wax up, different types of smile creator where you can bring in 3D face scans, removable appliances, and then provisionals. So you can make your custom healer for the implant before you've even placed the implant, and you can time it all together in the software. So the day you drop your implant into the patient, you can pop in a tissue shaper, right? So just really smart, robust tools that work together really well. And so this is what that setup screen looks like. So it's kind of cool. You can see all the different options of what you can do. I mean, you can make your dentures, your partials, anything and everything you can do in the software. And then when it comes to 3D printing, our Momentarium, again, we have Sprint Rays and Einstein and a D4K. So I typically gravitate towards the Desktop Health family of printers. I love the NanoFit 385 accuracy. So it's a really beautiful, clear, precise material. It's also super quick. And the actual integrity of their projector, it's a true industrial chip. So it's a really high quality printer. And again, just user-friendly, small footprint, all the things that I love. And then these are the accessories. So if you are into 3D printing, you'll know that it's not just the printer because you have to process it after. So we have our washer unit and our curing unit. And it's important to keep in mind that with the FDA approval of these materials, they're cleared within their own ecosystem. So we don't want to take something that's printed on a different manufacturer's printer and wash in a different wash unit and cure in a different cure unit. It's important that we're hitting these resins at the correct wavelength to make sure that we're actually setting them and not leaching monomer into people's mouths. This is just it's a different angled photo, but it's the same surgical guide, just printed on both printers. And again, this is the difference between the wavelengths. So you can see it's a little bit clearer on the Einstein versus the resin, the surgical guide resin on the Sprint Ray, but they're both super functional. They both get the job done. And then this is our 5-axis mill. So this is really for puck milling or zirconia. So oftentimes we'll actually, if we're milling a implant crown, we'll mill it on this mill. We can mill it on our 3-axis mill, but with a 5-axis mill, it's a little more fine detail. So if we want to do a screw mentable crown with a hole in the middle of it, this can do that with that level of precision. We can also mill the surgical guides out of a puck as well. If you're not familiar with puck milling, puck versus block milling, pucks are super duper affordable. So you can get 20 plus crowns out of a puck, and typically a puck is less than $200 versus each individual block. So it's just a very economical way of doing things. And then also too, if you're doing, hybrids or bigger sort of implant supported cases, that kind of stuff, of course, needs something bigger to mill it out of. So things like a puck are very useful for that. This is an actual puck. It looks photoshopped, but it's not. This is actually a photo of a puck where we had milled an occlusal guard out of it and then a surgical guide out of it. So that's an acrylic type material. So whether you print or mill, again, super functional. Use what you've got and make sure that what you have is multi-purpose, right? And then this is our 3-axis mill. This is the 30S. They have a newer mill, the 35, which would replace this now, but this is what we currently have. And again, same thing. So we'll use this sometimes for the final restoration. And so this is a photo just showing how advantageous it is to actually, do the final restorations in your office. So the arrow's pointing to, tooth number 5. So this is actually an implant crown that we milled in our office. And you can see it's a little off. It's a little light, right? But is it light enough that we're going to wait 2 weeks for turnaround time if you have to send that to the lab? I don't know, right? That's a conversation that you have with your patient. But I know oftentimes if it's close enough, right, the patient will typically tell you, oh yeah, just throw it in there, it's fine, right? But then you see it at every visit and it haunts you at every visit that it's not perfect. So the beauty of having this stuff in our office is we can literally say, hey, you got 15 minutes, let's just stain it down a little bit, right? And take it to the back and stain it down. And this is a literal photo that I stole from my assistant who we wanted to, stain this half a shade or 2 down. And so she took this photo, went to the back and stained it right down. So I have to get a photo of it when the patient comes back in. This is literally the assistant's photo that I stole. And so, then we can make it perfect, right? And that's, again, really advantageous. And then there's a lot of conversation and a lot of consideration to printing implant crowns. So printing is really accurate, arguably possibly more accurate than milling, right? We have some research that tells us that. And it's really affordable. So you can print a crown for 69 cents. But in addition to those factors, there's some notable advantages to printing crowns for implants. So implants, of course, lack a PDL space. So there's thought that resin will kind of help dampen some of that force versus zirconia, which will transmit that down through the implant. Resin crowns will also wear more naturally versus zirconia crowns. So we don't leave things in hyperocclusion and cause occlusal issues for implants over time. The other consideration with the resin crown is 50% of all implant crowns end up with an open contact. So with the resin crown, right, we can easily add to that and close that contact, or even reprint that crown for another, 69 cents. There's also some issues with milled types of materials, debonding versus printed materials. We found have a longer, more predictable bond. There's just more free methacrylate in it. And printed resin versus direct resin, the degree of cure is exponentially better. So it's a stronger material when it's printed indirectly versus when we're curing it with our curing light in a patient's mouth, right? So it's similar to the resin we use for restorations, but it's different, right? This is a hybrid. This has ceramic particles in it. So it is a different type of material with, better qualities to it. So other considerations there. Talking about crown down treatment planning, right? So again, we want to produce the most optimal aesthetic outcomes for our patients and long-term functional and healthy. So our implant workflow, again, we're going to do our CBCT, our full arch scans. We are going to either design the wax up ourselves, or we can outsource that, right? We can pay somebody $20 to design that wax up for us, and then we can make the surgical guide, or we can pay them another $100 to make the surgical guide, in the lab, right? So there's so many different ways to plug yourself into the equation. It's just a matter of how you want to do that. Full arch scanning. So for the sake of time, I'm going to kind of blow through this, but I have this in here just showing how kind of, easy that this process is, how quick it is. This is a really amateur assistant scanning, following no scan pattern, not doing everything kind of the wrong way that they're not supposed to. And we still get all the data that we need in less than a minute. So again, we take our upper full arch, our lower full arch, and our bite. So I'm going to kind of skip through this here just for the sake of time. And then the second step, of course, getting our CBCT. So this is a patient that came in, fell, chipped my tooth, right? So we know there's trauma. We know we want to get our CBCT. And of course, it's never like it seems. So, CBCT will help us not only plan more implants, but find more implants, right? And make sure that we are rendering the correct treatment for our patients, because a filling is certainly not the answer for this patient who was completely asymptomatic. So we take our CBCT there. So prosthetically driven implant planning, again, we can use the PlaidCAD Easy Software, which would be in Romexus, or we can use the PlaidCAD Premium software, which is its own lab grade software to create a virtual wax up. You can use the existing tooth if it's not been removed yet. You can just scan and use that. And then we're gonna make our guide from that. And again, you can always outsource that stuff as well too. This is that virtual wax up process. So I have it split screen. It's the same tooth, the same files. The one on the left is going to be in Romexus, and then the one on the right is going to be the lab grade software PlaidCAD Premium. So you can see the difference here and just sort of how long it takes and what that process is like. So in Romexus and PlaidCAD Easy, which would be like what we use for same day crowns, that process, it's just like if you were designing a crown, but there's no margin, or there's no tooth, excuse me. So we draw our margin around there, and then we're going to fit a tooth and kind of size it and adjust everything. On the right-hand side, that's the PlaidCAD Premium software. So what I'm doing there is literally just saying, hey, I just want a exact carbon copy mirror image of the neighboring tooth. So I can choose from a tooth library if I want to totally reinvent the wheel, or my favorite, which I do all the time, is I just take whatever tooth is on the contralateral side, whatever tooth it should be similar to, and just say, mirror that for me. And if I want to adjust that, I can, of course, if there's wear on it or other things I want to do. But that's a really easy, predictable way of doing it. And then there's little buttons in there to say, cut the occlusion in perfectly, cut my contacts in perfectly. And it's literally a couple of clicks of a button, and you can do a virtual wax up. So we are 1 minute and 24 seconds into doing this process. So you can see how quick and easy it is. We're almost done with making sure our occlusion's right, checking everything, making sure we like the way it looks. And about 1:30 minutes later, we're done. And that's all we need to do. And so the lab grade software is a little bit quicker and easier. So that takes a little bit less time. On the PlaidCAD Easy Software, you can see I'm still kind of adjusting my contacts, which really don't totally matter for the purpose we're going to do of planning an implant, right? We really just need sort of the basic contour. But, we're sitting in here kind of making sure that that tooth is exactly how we want it to be. So again, we can make sure that we're planning our implant to be in the exact perfect position that we want it to be. So this one took me a little over 2 minutes, about 2 minutes and 15 seconds in the PlaidCAD Easy software. And if you have a analog wax up, you can turn that into an STL, right? You don't even need a scanner. If you have a CBCT, you can take your analog wax up, put it on your CBCT and scan that. And that's what this is doing. This actually turned a physical wax up right into an STL file. And now I can overlay that on my CBCT, right? And plan my implants there. So, the sky's the limit with this stuff. It's so cool what we're able to do with it. So within Romexus, again, all of our data lives. So we can merge any STL file, any scan with our CBCT, with our DICOM data. You can even just pick a generic tooth. You don't even have to make it a custom wax up. You can use a denture and scan the denture and overlay that as well. And then again, we're going to plan our implants and it'll tell us if we're going to collide with another implant, if we're going to collide with a nerve. We can make implants parallel for planning a bridge or, doing multiples and wanting to tie them together. Whatever it is we're doing, we can accomplish that. And within Romexus, there is an integrated implant library, and it is crazy robust. So I put over 90 manufacturers and evolving. It's well over that at this point from when I've done the slide. And so it's constantly evolving. And no matter, what guided system you use or what type of implant system you use, you can do anything and everything. You can also plan your guide for a fully guided surgery, or if you just want your pilot drill and then you want to take it from there, you can do that as well. You can time the implant and time the sleeves. So again, you can digitally in Romexus put your implant scan body and then use that information to create your pre-surgical provisional and your healer. So it can all snap in at the same time. So it's just mind-blowing what this stuff can do and how much time it can save you, but also how precise it can really be. So this is sharing that guide design process. So I'm drawing the panoramic curve here on the CBCT, and I've already designed the tooth in PlaidCAD Premium in this case, marking my nerve, double checking, making sure I have it exactly where I want, kind of slicing through. And now I'm going to marry all the data. So with a couple clicks, because it's all housed in the same place, I'm going to take the arch. And so this is the scan that we took with our Emerald S. And I'm going to tell the computer, hey, here's roughly how to put these two pieces of information together. And then it's smart enough that it'll take it and it'll kind of fine tune and auto tune it. So I select 3 points from each just to kind of orient it. And you can see it's finding the closest match. And then it's going to use automatic match. So I'm double checking. Yes, it looks like it fits perfectly and intimately to all of our teeth. So now I'm going to take that little tooth that I waxed up and it knows exactly how to orient it because it's all housed in the same software. I didn't have to tell it where to put it. It knows how to orient that wax up to the actual STL scan itself. And then I can sit here and I can play around and manipulate this however I want, check to make sure that I'm in bone, use that implant centric view to spin just around 360 around my implant, look at, how is that coming through my restoration? How is that coming through to contact the opposing tooth? I can add guide sleeves if I want to do a guided surgery. I could do whatever I want to do, kind of switch colors, turn it off, look all around, right? If I was really doing this, I'd probably make it a little bit more mesial. But basically just look at, what it is that I want to do to get my implant to the most optimal position. And then from there, I can launch right into my guide design software. So super easy. I'm going to orient, what path of insertion I want for my guide. I'm going to draw the guide. How many teeth do I want that to cover? Where do I want that to cover? Kind of check that out, preview it, and then edit it down. So I can make it as big, as small as I want. If I want cross-arch stability, I can add bars. I can add patients' names. I could do anything and everything I want to it. I can cut out little windows, which we'll do just to make sure that it's fully seated. For the sake of time, I'm going to kind of skip through the rest of this, but you can see this is really easy now to either print or mill, and we almost have it designed here. So once we've designed it, the system will automatically kick back a implant report. So the implant report, again, gets housed in Romexus, and it keeps everything super organized. So whether it's for ordering or for a day of surgery, it'll tell you what implant you need, what drill type and length. It just gives you all the information that you need for your surgery to make sure you're prepared. If you're placing multiples, they're really helpful to have up in the room. I will always kind of put them up on our back computer so I know exactly what I'm doing and where I'm doing it. And so those reports look like this. So it'll tell you, okay, for this implant, I'm using 28 millimeter drill length. For the other implant, I'm using 24 millimeter drill length, and it'll tell you exactly what it is that you're doing. And then again, you can make those provisionals. So this is actually a dentist who found me. Someone placed the implant on her. They had temped it for her. Her temp came off or broke, and she walked into my office and said, "Can you temp this implant for me?" And so it was so easy to just scan the abutment and then mill or print out a little crown on there, right? And we bond that right on, and she's out the door. So super easy without having a model or without having anything to do, right? We can digitally design that and get her an implant temporary back in few minutes. So our bonding protocol, anytime you're bonding, we use air abrasion, universal bond, which also has the primer in it, and then a resin cement. So I'm going to go through just a couple cases of just implementing this stuff. So this is Scott. Scott is, of course, missing a front tooth. So this is kind of a little bonus. So in PlaidCAD Premium, prior to Scott being ready to have an implant, we made Scott a little flipper. So that's what you can see here. So again, PlaidCAD Premium, you can do anything. I really love these little flippers. They're fun. You can also do an adhesive bridge if you don't want to put pressure on the ridge. And what's really cool about some of this material is you can see that based off of your design and the thickness of the material, it actually affects the mechanical properties. So if it's thinner, it'll flex more. When it's thicker, it flexes less. So you can really utilize that and play with that as well. So we designed Scott's tooth. And from there, we merge all of our files together, just like we showed and we talked about. And then once we have that data, we can plan the implant, right? So I wanted to do a screw retained restoration. So I'm going to orient the access of my implant through the cingulum rather than through the incisal edge. So those are decisions that we can know ahead of time, right? Before the implant's even placed, I know what type of restoration I'm going to use on the patient. So again, really powerful stuff. So we can communicate effectively, plan effectively, and make sure that we can prepare our patients and know what we're doing. So again, we plan our implant, we make our guide, and then we place our implant, and we actually milled this crown in our office and place that as well. So similar concept. So this is definitely an implant where prior to doing surgical, guided surgeries, I would have referred this out. This is a tight space. Placement is really critical. This is something that I would not have done, right? And in this case, I have to do a cement retained restoration. So again, we place our implant, we mill our crown in our office. This is a patient that was a bruxer. So this is a little bonus. We 3D printed her a guard as well. And then that tooth number 10 is milled in our office on the implant, right? And then again, it works really well if we have multiple implants. If we're doing bridges, we can, parallel them really easy. So we do wellness scans, our hygienist scan in our office. So we like having more data. There's never been a time when I've regretted having a scan, but there's definitely times I regret not having data. So this is a patient where we had previous scans, and in a matter of like a couple weeks, he somehow ended up breaking 2 teeth, older gentleman. So no problem. We didn't have to do a wax up, right? Because I have his scan. So we're going to base it off his existing teeth, and we can make a surgical guide. We can place those implants. If we want to do it flapless, right? We could do it flapless. And then in this case, we restore them. We scanned with scan bodies. So that's what this picture is showing. And then we can coordinate with the lab so that they'll send us the STLs so we can mill the crowns in office, customize them however we want, or print them. We've honestly been kind of splitting and doing a little bit of both. And so we get those files back from the lab, and then we're able to deliver our final restorations. Same thing with an immediate. So this is a case where the tooth is still in there, but again, we can plan and we can look and tell this patient, can we do an immediate implant? Do we need to do more of a delayed approach? So being able to just really understand and assess, but also really communicate and explain that to our patients, right? So they know that we have their best interest at heart, that we're looking at all the parameters and what limitations we can overcome versus, what biology we need to respect. So tooth is removed atraumatically. This is a surgical guide printed out of the Sprint Ray guide resin. So just kind of showing that in there with our guide sleeve in there, and then being able to place that implant. So, overall, I obviously love digital technology. It helps me so much with efficiency and accuracy, with communication. But I never want to give anybody the impression that you have to be digital, right? Do we have to be digital to be a great dentist? Of course not. We have so many great dentists, and have for years before all this digital stuff has come into play, right? But the beautiful thing about digital technology is it just makes it so much easier to be consistent and perform at our best and provide, the best service we can for our patients. So it's really just about making our job more predictable and easier, because we have all the frustrations in the world we don't need anymore, right? And then I have to give a shout out to Dr. Wally Renee and Dr. Michael DeFee. They are partners in the Mod Institute. That is the digital dental residency that I was talking about at the beginning. They've been tremendous mentors and friends to me along this journey, and they've taught me so much of this stuff. And so I definitely encourage you to join the 3D printing and Facebook group if you're not a part of that group, and check out their institute if this is stuff that you're interested in and you're looking to learn how to get more into design and printing and milling and these types of workflows. So definitely check them out. So that is my information for you tonight. So thank you guys so much. I know this went, we're still under an hour, but I was hoping to try and wrap this up in about 45 for you. So appreciate your time and attention. You can tell I get geeked on this stuff. So thank you so much. I really appreciate your attention, and I'm here for any way I can help, and any of you on your digital journey. So thank you.
Thank you so much, Dr. Gantos, for such a wonderful presentation. As mentioned, we can open up the floor for any Q&A anyone may have. You can type it in the box labeled Q&A. And if not, feel free to email us at the email address that will pop up on the screen, and we can get those questions answered for you. We have one question. What is the info on the Mod Institute?
Yeah, let me go back to that right there.
Perfect. Awesome. Thank you so much. We can wrap up tonight. Thank you everyone for joining us. We did record tonight's webinar, and we'll email out the recording sometime in the next week. We would appreciate everyone's feedback on our survey that will pop up on your screen shortly. And all questions that come through, we'll definitely make sure to have them answered for everyone. Thank you all for joining us again, and we look forward to seeing you on future webinars.
Thank you, guys.
Good night.